My next talk will be on principles of limb salvage surgery. In order to understand limb salvage surgery, we have to look at the history of limb salvage surgery. In the pre-1960s, survival for malignant bone tumors was only 10 to 20%. Therefore, amputation was the treatment of choice. Then came the era of between 1960s to 70s, where chemotherapy was introduced and the survival of patients with these tumors began to improve. Then in 1980s, the survivals continued to improve, and there was improvement in image modalities such as MRI and CT scan that gave us a better impression of the tumor and the margins, and we were able to resect the tumor with better margins. This led to advancement in resection approaches and reconstruction techniques for the limb preservation. Then in 1990s, there was improvement in implant designs. We could get custom or off-shelf prosthesis available. Allografts were also available, and there was improvement in rehab protocols. In the late 90s and early 20s, newer agents and regimes were introduced for the management of these tumors. Endoprosthesis and surgical approach and reconstruction techniques became more refined, but survival rates remain around the same, as if they reached a plateau. Currently, where do we stand? There is introduction of targeted or selected chemotherapy regimes. The survival rates are around 80% for non-metastatic bone sarcomas. The overall survival is around 60 to 70%, and local recurrence rates are less than 10%. When we talk about limb salvage, the areas of concern is the survival, the local recurrence, the mobility, the function, and the psychosocial benefit. The principles of limb salvage surgery is that there should be no delay in chemotherapy as it will compromise the survival. We have to achieve a good wide margin to prevent local recurrence. Reconstruction has to be long, lasting, and robust. And the functional outcome of your reconstruction has to be better than amputation.